announcements. Firstly, the new SMCI website has launched, and I'm told to clear your browsing data and keep persevering to get the new version. I think there's an issue with some cookies, but so the new website's launched, and there's also a new QI toolkit that's available. It's got a lot of great resources for those of you doing quality improvement work, so please check it out. So moving on to today's presentation, I'm honored to introduce today's speaker, Dr. Justin Baker. Dr. Baker joined Stanford Children's last year and is currently the Inaugural Chief of the Division of Quality of Life and Pediatric Palliative Care, as well as the Director of the Quality of Life for All program. Prior to Stanford, he was at St Jude's Children's Research Center, where he started the St Jude Palliative Care program and created 2 home-based pediatric palliative care teams. He also served as the director of the Pediatric Hematology Oncology Fellowship Program for more than a decade. He has a remarkable research career with over 300 publications on innovative models in palliative care, grief and bereavement, patient-reported outcomes, and pain and symptom control. He has received many awards for his work and was recently named a visionary in hospice and palliative medicine by the American Academy of Hospice and Palliative Medicine. And so without any further ado, I'd like to hand over to Dr. Baker. If you have any questions, please go ahead and put them in the chat. Thanks, and we'll save them for the end.
Yes, thank you so much for inviting me to be here, friends. This is awesome. It's such a joy to be here, and I see many of you on this webinar that I've met before, and many who I have not. And so I am excited to be here, grateful for the opportunity. Another role that I actually have is really in SMCI. I work in the Center for Pediatric Maternal Value as the Associate Chief Quality Officer for Patient Experience and Holistic Care. And so although I've spent the vast majority of my time and effort recently in starting our new division of quality of life and pediatric palliative care, I'm hoping to expand and be more present with you all in this amazingly important work, and very grateful for the opportunity to be here with you today. As we get started, I'm very glad to speak about pediatric palliative care. And we're going to talk about some of the barriers, going to mostly speak about some key evidence strategies to implementing pediatric palliative care. And interestingly, I'm hoping that as we talk through this, you're going to realize that it's actually that all of us can do a better job in each area that we're working by leaning in and leaning in with an open heart. And I hope that comes through in this presentation. Sometimes I wonder, because this is virtual, that maybe it doesn't come through quite as much as I would in person. But anyway, if we were in person, I'd be throwing koalas at you because, as mentioned, I'm leading our QoLA program. QoLA stands for Quality of Life for All, and you'll hear more about that too. As we get started, I wanted to frame this a little bit in the work that we do every day and introduce you to one of my patients and families from St. Jude. When I think about Jessica, I am immediately reminded of her smile. You would walk in the room and right away you would know what her mood was. And boy, when she was in a good mood, that smile would light up the room. And boy, when she was not, she would let you know.
You couldn't meet Jessica and not remember her. She loved the staff, she loved entertaining. She knew she had a gift for making people feel good, and she loved to use that gift.
She was always full of life. She loved to joke. Oh, she was a Florida Gator fan. For the art teen show, she made a poster with the Florida Gators that was chomping up the cancer.
She believed in her heart of hearts, as did her parents, that she would absolutely be cured. And it was with that spirit, that spunk, that larger than life attitude she approached every day. Then when the tumor started coming back, it just came back raging. At that point, there really was very little that we could do to control it, certainly not cure it.
As it became more and more obvious that she wasn't going to be out of the hospital for the remainder of her life, it was all about how can we make these days brighter for her.
Jessica asked if she could have a puppy from the Make-A-Wish organization. Having a puppy in an inpatient setting is not a simple feat.
Anytime you enter an animal into this environment, there are so many things that have to be done.
We can't just break every rule and say, okay, well, let's bring the dog in.
You have to think about people with allergies, people who don't like dogs.
The fact that we have other patients here too.
Where's the dog going to be? Where's he going to stay?
Who's going to be responsible for the dog?
But with all that consideration, how can we make it happen?
Just to make that one event happen, so many people have to be involved in that.
No matter whether it's infection control, nursing, environmental service, security, everyone gets together and we come with the blueprint. It was our job to make sure we were ready.
We went over to the outside gift shop and we found these flags that go on the car. We bought one of those. I took it home and designed it to make it into a vest.
When he came in the door, his tail was wagging, his nose was up in the air, didn't show any signs of anxiety. Once we saw the personality of the dog, we knew that he was going to be a good fit. We knew that everything was going to be all right.
Shadow came and had his vest and had his badge and came through so smoothly through security and made his elevator ride up to the floor and enter Jessica's room.
They take Shadow over to the bed, and she was kind of groggy, and she wakes up and she says, "I love you." And she touched his head, and then he laid down.
The initial meeting between the two of them was just like it was just supposed to have been that way. It was just amazing.
She was so excited, and the room was so full of joy.
She was going to be able to sleep that night with that one major dream fulfilled.
It was sort of this triumphant moment of all of these things that we've done, which may seem minor, all came together in this one moment where you realize that everything was worth it to give her this incredible wish come true at the end of her life.
Shadow made a huge difference. I mean, a huge difference in Jessica. She suffered tremendously, and Shadow would crawl next to her and be a source of support. And so seeing the difference that Shadow made, you immediately knew that it was not only the right thing to do, it was the perfect thing to do.
It's hard as a physician, as a scientist, to sometimes say that there are limits to what we can do with the tools that we have. Shadow was actually almost like part of the medical team. He was able to help us give her some of that comfort and achieve more than what our medicines could offer.
Jessica knew that she was dying, and she wanted to leave her parents something that they could tangibly have of hers, and that was her wish.
Shadow is playful. He loves to play hide and seek. He loves to chew on empty water bottles and make them squeak and run and slide, and it makes them laugh. There's a lot of Jessica's personality in Shadow.
It's hard to describe the love that was in the room, but you could see how much it meant to Jessica, and you can see how much it meant to her parents.
I really think that that's what this place is all about. That's what St. Jude is all about. It is certainly about finding cures and saving children, and that has to be what we're emphasizing. But at the same time, it has to be about making every day the best day it can possibly be for every child. In this case, the way to do that for Jessica was by helping Shadow come and be a part of her life. Being a part of her family for those last days of her life made all the difference. And I'm so grateful to have been a part of it. I gotta tell you, it's just such a privilege to do this work. And as I talked about, koalas surround me. Every part of the work I do has koalas in it. I'm very easy if you're looking for a holiday gift to get me anything koala related, because koala means quality of life for all. I'd also encourage you to look at a TED Talk that I did in Memphis, a TEDx, and it's labeled "What Dying Children and Their Parents Taught Me About Leaning into Suffering." And really, when you think about palliative care, it's this extra layer of support for sure, but it's also really about what that TED Talk is about, which is about compassion and this concept of truly suffering with our patients and families. And suffering is really the actual disease, and you'll hear me talk about this, that as a palliative care doc, that's the disease that I treat. And I'm so grateful to be here at Stanford now with the QoLA that came originally from St Jude in Memphis. And so I'm an oncologist, and as an oncologist, the disease I treat is cancer, but I'm also a palliative care doc, and the disease we attend to in pediatric palliative care is suffering. And most of you will know that this is, or many of you will know that this is one of Munch's paintings, but probably most of you don't know who Munch's muse was. Yep, that's me. We got to go to Norway this summer, and it was, I guess this is actually now about 18 months ago. And it was very cool to go to the Munch Museum. Very wonderful spot if you get a chance to visit there. And so we have to ask ourselves, how do we best attend to suffering? Well, suffering is tremendously individualized, and it really is a specific state of distress that occurs when the intactness or integrity of the person is threatened. And so it can come from all these different angles, and we have to actually think about suffering holistically. And we were talking earlier at the very beginning of this meeting about Dame Cicely Saunders, who taught us, really invented hospice and started the movement, and really talked about this concept of total pain. And what we're conceptualizing and recognizing now is we have to also take that into suffering of all types. And what is total suffering as it's related to cultural issues, social issues, certainly physical and pain related issues, spiritual, psychological, and all of these happening in the context of this patient and family like Jessica that you just heard about. And interestingly, it's also about how do we integrate the meaning of suffering. And there was a time, and many of us will remember this, in kind of Northern Ireland, where there was a lot of terrorism. And I remember the first time I ever heard of the concept of terrorism was these difficult moments. And this window actually is a stained glass window that comes from a church that was bombed. And you can see this written. This window is memorial of the bomb blast of the 5th of August, 1981, and the subsequent restoration of our church and halls. It's a tribute to our neighbors and shops and offices and their will to overcome disaster. It is an echo of the motto of this town, Ex signe resurgam, I will arise from the fire. It is a witness to our faith in the Lord Jesus Christ. And interestingly, this stained glass window was created out of all these gorgeous stained glass windows that were broken in the bombing, and they re-put these shards together to make this. And so that's also something that we have to think about, is in the concept of suffering, like how do we reconceptualize or bring together the meaning of suffering? And I'll tell you, it takes really specific tools and attention to aspects of care. And the most important tool that we actually have are our ears. And this is usually funny because I give these talks to a lot of doctors, and when I ask people what are the most important tools, a lot of times they'll say things like morphine or stuff like that. But anyway, we are doing this virtually, and I have a hard time seeing the chat right now, so I didn't get to ask you that. But I will tell you the most important tool is the same tools that my grandmother used to tell me, that kind of God didn't give me two ears and one mouth for no reason. And we have to be really listening with a willingness to be changed by what we hear. And it really takes a humble curiosity. And we have to have a compassionate and a soft heart. And interestingly, when we talk about a soft heart, that means that heart has to be willing to react, to respond, to suffer with our patients and families. Also, it takes a team. Like I see all of you here in the gallery view, and I can see that we have all sorts of different disciplines. Well, that's exactly what we need. We need to be able to look at suffering from all these different angles as we think about how can we best care for this precious patient and their family. So these are the key concepts. That was a little bit of an intro to get us to where we're going to talk about some key evidence-based concepts that can improve outcomes in these precious kids and their families. And the very first one is that communication matters. And it's this seems so self-evident. In fact, sometimes when I share this slide, I say, We published this in the Journal of Things That You Already Knew. Communication matters. And when we think about this, our words are the procedure that we work towards. And similar to scalpels for surgeons, words are the palliative care clinicians' greatest tools. Surgeons learn to use their tools with extreme precision because any errors can be devastating. So too should clinicians who rely on words. Or this precious mother told me, the way you tell the truth to families makes a huge difference. If I know you're coming in and telling the truth, even if it's terrible, but I know you love my kiddo, I know you love us, we're going to get through it. And when I think about telling the truth, I always come back to Emily Dickinson's poem because I think this is the beauty of the work that we do. There is strong evidence to support excellence in communication, and it is an art as well. Tell all the truth, but tell it slant success in circuit lies, too bright for our infirm delight, the truth superb surprise. As lightning to the children eased with explanation kind, the truth must dazzle gradually, or every man be blind. We also have to recognize, and I saw many from our patient experience team and child life and others that are also a part of this. And in moments like this, I just need to give a big shout out to them. And Liz, I saw you on here as well. And I mean, I've been taught by some of the very best child life specialists and child psychologists, and the main thing we need to make sure is that we are bringing these kids into this process with us. And that doesn't mean we communicate that with them in the same way. We need to help them feel not alone. And I like these 6 E's, but the most important of these 6 E's is the second one, and that is engage the child. Engage the child, like figure out how to engage the child in the process. What does that mean? Maybe that's playing, maybe that's involvement of the entire team, maybe that's working with child life, maybe that's coaching the parents. But we also have to establish open communication, explore what the child knows, explain the information in a developmentally appropriate manner, empathize with the child. That's very much of a opening of our heart, and that's the human connection component that also needs to happen with children. And then we need to encourage the children. And actually in much more recent literature than this actually was published last in 2022, was the concept also of fostering hope and supporting hope. And that's a lot like this encourage statement. The next thing I want to tell you is that we need to establish an effective therapeutic alliance. We need to provide relationship-based care. And in this era of virtual communications, virtual seminars, this is very convenient, but it's actually a little bit harder to provide relationship-based care. And so we need to figure out and recognize what a huge difference it makes. Well, we've written about this. We've written and provided guidelines for developing therapeutic alliances and how to deepen those relationships. And the beauty of this, the beauty is that it could really come down to this concept of human connection. And you're like, Justin, that's so soft. Does it really matter? What do you know? Well, I'll tell you, the cool thing is the deeper we connect with our patients and families, the more trust that they have in us. Families have decreased decisional regret and improved psychosocial outcomes. This is in a variety of studies and a variety of outcomes. And so this really does matter. This is not a soft skill. This is a outcome improving skill. And like I mentioned, it comes down to trust. And so how do we think about trust? What is trust like? Well, I think of it like a piggy bank, and you have to be investing in it. This is a paper I wrote with a colleague, Brian Sisk, where we talked about there's all different aspects of trust, and that trust is competence-based, but it's also relationship-based. And in this relationship construct, we have to think about building trust, maintaining trust, and then think about what happens when trust is broken. What are we going to do? How do we rehabilitate that relationship? And this is a really important concept and absolutely improves outcomes. Next, we also have to recognize that empathy and relationship-based care, that we kind of break our patients and families, unfortunately. This is a question I ask every single patient and family. And I don't know the exact percentage, what I'm going to tell you, but it is definitely the plurality. The most common answer given to how has being sick been for you and your child. I'm going to pause for a minute, just have you think about it. What do you think is the most common answer there? Okay, I'm going to tell you, many of you thought terrible, awful, overwhelming, those kinds of words. Those are all said, but they're usually said second. Because the first thing most families say when I ask them, how has being sick been for you, is they'll say, well, little Johnny started with a limp about 6 months ago. And then he went into the pediatrician, and I tried my very best, but I couldn't get the x-ray done in time. And we've so medicalized people that we ask them, how has being sick been for you? A very affective question. We've broken them into just telling us their medical story because we have basically converted the mentality to feeling that their entire humanity is contained in their illness. I mean, it's so terrible how the medical institutions have done this to people. And this happens all the time. All the time. It happens all the time in how we speak about patients. It happens all the time in how patients receive that information. And we've got to do better. We've got to do better. And when I think about this concept of empathy and even beyond that, compassion, I think Brene Brown says this so well. And at one point where you'll see this strange looking animal, maybe it's a deer, I don't know what it is, but it says, anyone want a sandwich? Nope. You'll hear that. And at that moment, when you're really debating, am I going to connect or not? I just want to challenge you in the future. Think to yourself, what can I do to better connect with this person in front of me? Because it will make a profound difference.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, and climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. Yeah. And we do it all the time. Because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So, I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now, I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
What makes something better is connection. And you might again think, is that really true in the most difficult of difficult situations? And I might have challenged it also if I hadn't had 25 years of experience doing pediatric palliative care now. And I want to tell you this story about this remarkable young woman named Emma. And she actually had the same disease that Jessica had. And it was a very almost incurable chance. She had less than a 10% chance of being cured. She had stage 4 alveolar rhabdomyosarcoma, and that's a real problem. And unbelievably, she was cured. She was diagnosed at age 14. At age 19, she was unfortunately diagnosed with treatment-related acute myelogenous leukemia. And so it was because of the treatment she received to cure her other cancer. And she was studying actually at NYU at the time, studying political science, and came down back to St. Jude again to now get a bone marrow transplant for her treatment-related AML. And when I met with her as part of our kind of standard approach towards treating patients with that have bone marrow transplant needs, I met with her and it was clear that she was in this dark hole. In fact, she talked about being in a deep dark hole. And the biggest problem was her diarrhea. She was having 3 liters per day of diarrhea and had really lost her independence. She was having to wear diapers. It was a very difficult time for her. And so I met with her over the next 7, 8, 9 days. I met with her 4 or 5 times and made all sorts of phone calls and did everything I possibly could to figure out how to better treat her diarrhea. And a weekend went by and I saw her on a Monday. And I remember thinking to myself, oh, yes, her diarrhea must be so much better, because there was just a lightness, a brightness in her eyes. And I walked in and that was the first thing I said. I said, Emma, how are you doing today? It looks to me like your diarrhea must be better. And she said, no, Dr. Baker, I'm still having 3 liters of diarrhea, but talking to a compassionate listener like you has helped me feel like a new person. In fact, even though her diarrhea was exactly the same, she felt so strongly that by listening to her, by addressing her other needs, which really were very much just an empathic, compassionate approach towards her care, she wrote the New York Times, and this was published in the New York Times, as you can see, in 2017. And really, this empathy, compassion, it makes a profound impact in all aspects of care. As we think about the next aspect of what I wanted to share with you today, it's really thinking about goals of care. And it's really common that in pediatric care in general, people say, this is the diagnosis, this is what we do. And maybe it should be, but you're going to hear me talk a little bit about this, because without knowing the goals, we're simply doing stuff to the patient. And decision making, I've studied every aspect of these components of this. I kind of created this paradigm to think about in patients with incurable cancer. And you can see all of this. These are difficult steps every place along the way. Salvage chemotherapy, experimental trials, palliative, quote unquote, chemotherapy and what that means. No further cancer-directed treatment, thinking about making decisions related to DNR and desired location of death. All of this is happening in the midst of tremendous suffering. It might be happening in the middle of breakdowns in communication. So this paradigm, even though it is better understood now for us in this field, it's incredibly difficult to communicate to families. And we have to realize that when we're thinking about goals of care, it's these goals that really should be foundational in the care that we're providing. And these goals, interestingly, they themselves are always evolving. And there's these evolving life and medical goals as we go along. Also, interestingly, even though it's that last goal, live as well as possible, comfort, that uses the word comfort, families always have a dual goal of comfort. They always want it to be a yes and. I want to pursue any treatment that might cure my child, and I want them as comfortable as possible. So we really need to put this hand in hand. In fact, I would always say this at St. Jude. It was finding cures, saving children, and I would then add in, and making every day the best day possible. And so that was how we came in hand as palliative care partnerships. And these are all the things that drive decision-making in pediatric palliative care. It's suffering, it's how families define a good day for their ill child. Prognosis certainly is a factor. The child's wishes are something that we're recognizing and needing to integrate more and more. You'll hear me talk more about that. Hopes and values, relationships, and even how a parent defines being a good parent to their ill child. These are the things that should be driving the goals. The goals should be driving the treatment options and decisions. Interestingly, though, I think too often we do because we can, not really fully contemplating if we should. And when I say that, a lot of times people are like, here comes the palliative care guy telling us we're doing too much or doing too, whatever. And that's not what I'm saying. I'm saying we should just pause and think about things. In fact, sometimes I think we actually offer things up that really we think are bad options. We try to talk families out of it. And really, if a choice is only a choice if it's indeed a choice. And so if we think it's such a bad option, we shouldn't even offer it. And realistically, in the concept of shared decision making, I love this first step that Doug Opel wrote about, which is, does the decision include greater than one medically reasonable option? If the answer is no, shared decision making is not indicated. That doesn't mean we're not expert at communicating it, but it means we don't offer things up when there's really only one reasonable option. I think a lot of times hope gets lost in this, and we can't really recognize the importance of hope, or sometimes we think the only hope that matters is hoping for a cure. But again, I'm going to read this Emily Dickinson poem because it's just so beautiful. And hope is the thing with feathers that perches in the soul and sings the tune without the words and never stops at all. And sweetest in the gale is heard, and sore must be the storm that could abash the little bird that kept so many warm. I've heard it in the chillest land and on the strangest sea, yet never in extremity it asked a crumb of me. And hope is this complex emotional state, and it can be characterized by positive expectations, resilience, and a deep desire for a meaningful and peaceful journey for their child. Hope's important because it's an emotional coping mechanism. It provides a sense of purpose. It provides connection and support. It improves quality of life, and it's a balancing mechanism. So we all recognize how important hope is. Hope also changes, though, and I think that's something that is less understood. The hopes are different at initial diagnosis versus treatment and progression versus transitions and end of life and grief and bereavement. All of these different times are different. And when we think about hope, I want to share with you a story. It's an incredible story. It's this precious patient named Sierra. Sierra was actually 19, but she was first diagnosed also at 14 years of age with leukemia. And she underwent, this was her third bone marrow transplant. And we were meeting with her. And in meeting with her, this was an experimental bone marrow transplant. And I came into the room and I saw this room, and the room had this decorated on her window. And I wish I could tell you that I, very openly embraced this phrase, but I looked at the bright colors, I looked at this phrase of hope, and I was worried. But I was taught well, because when I'm worried, I know I need to sit down, I need to lean in, and I need to try to recognize what it is that somebody's hoping for. And so I said, Sierra, this is so beautiful. Will you tell me a little bit about what's going on? Why do you have that written on your wall? And she said, well, that's my very favorite phrase, Dr. Baker. She stood in the storm, and when the wind did not blow her way, she adjusted her sails. Hope anchors the soul. And I said, that really is beautiful, Sierra. Will you tell me what it is you're hoping for? And then she said something that I will never, ever forget. She said, Dr. Baker, I know I'm going to die from my leukemia, but I'm hoping by enrolling in this clinical trial that other children won't have to die from theirs. And I remember just, almost being knocked out of my socks. I was like, what in the world? This is amazing. And I just said, Sierra, thank you for sharing that with me. I hope that same thing. I also want to tell you, you taught me more about hope today than I've ever learned before. Can I take a picture of this window here in your room and share it with people when I get a chance to talk about hope? Because I think it's going to make a big difference. And so Sierra always goes with me and teaches us about hope. And so when I think about hope, I recognize that hope sustains every one of these goals. It doesn't only affect that hope for cure. We have so many different ways we can think about hope. The other aspect about hope that I'm told very often is, if hope is so important, I don't want to take it away, Dr. Baker. That's a bad idea. It would be terrible if I end up undermining hope. Well, what we know is that if communication is done appropriately in the context of a therapeutic relationship like we talked about, communicating very difficult news does not take hope away. In fact, it can sustain appropriate hope. And we used to think about hope kind of teetering between denial and acceptance on these very extremes of the not really seeing either of these on this really common basis. But it was weird because I kept seeing that it feels like these families actually are in this same place at the same time. And we began to work with these bereaved parents. I'd really encourage you to look up the study that we did. And these bereaved parents were incredible. They actually created this piece of art with us. And you can see in this left hand, this parent is watching the petals of their child's life blow away on the wind, while at the same time with the right hand watering their child's future, the hopes for the future. And this father, I think, said it the very best. He said, partner with us and witness the transformative love of hoping for the impossible and the improbable while accepting the painful reality that a rare and beautiful child is gracefully exiting this world. Partner with us. I think that's just so powerful. So this is one of the very most common questions we ask our patients. What are you hoping for today? What else are you hoping for? Oh, that's so helpful. Tell us, what else are you hoping for? And we use the language that we learn when asking these questions from these families to help sustain a realistic sense of hope. We also have to recognize that by engaging these children, that we can really help overcome this concept called mutual pretense. That's where kind of the parent and the child are kind of in opposite corners, each of them saying, I don't want to bother my parent because, you know, it's a little too much for them to realize that I know that I'm dying, or the parent to be like, no, I can't. That's too much. That's overwhelming. So they kind of use all their energy to protect each other. And this concept of mutual pretense is when we've got to get over. We have to help people think about these children's last wishes and really facilitate legacy development. And I'm going to share with you 3 brief stories. And this first one is a young lady named Amber. And Amber had a big tumor in the back of her throat, and she's getting pretty close to the end of her life. And we asked her what she was hoping for, and she said, I really want to see my baby sister born. And we thought, oh my goodness, we don't think she's going to make it. And then we thought about maybe we should place a tracheostomy, and maybe that would help her get there. And you can see in this picture, she has a really fresh tracheostomy, and she's sitting there actually holding her sister in the delivery room. It's so powerful. But I love this one even more. When we were caring for her with one of those home-based care teams that I was telling you about, we took care of her and her little sister in her home after they did get to go home. And you see how much longer her hair is here. And she was able to actually take care of her sister for about 2 months. Or one of our patients, he said, I want to have a birthday. It wasn't his birthday, but he wanted to throw a party for everybody. And so we decided to make it like a birthday party. And he said, it's got to be Minions related. And this is a cake. It was a delicious, delicious cake, I can tell you. And, you know, so think about it. Kids want to be kids. And a lot of times kids want to have a party. And so we have to think about how we can do that. Or this precious other patient, and we're definitely not supposed to have favorite patients, and the clinicians in here know that's not a good idea, but this was probably my favorite patient, or one of my favorite patients. And she decided to work with our child life specialist and our music therapists, and that group together, the child life specialist and music therapist, they made beautiful songs for every one of her loved ones. And this is the song she sang for her mama.
I found a love for me. Darling, just dive right in and follow my lead. Well, I found a girl, beautiful and sweet. I never knew you were the someone waiting for me. We were just kids when we fell in love, not knowing what it was. I will not give you up this time. Darling, just kiss me slow. Your heart is all I own, and in your eyes you're holding mine.
I never know where to stop that, but I would love to just sit here and listen to the whole thing. I find my heart rate slowing. I find myself really centered on the things that matter when I hear Precious Lizzie sing that to me. And I just can't imagine how many regrets her mama would have if she didn't have it, which gets us to the next point, which is We really have to try to prevent regret. In fact, we have to think of ourselves as being in the regret prevention business. And when I think about this, I like to think of myself even as a superhero of regret prevention. And I'd encourage you to look up an article that Sarah Wildman, again, that's Sarah Wildman, Wildman, just wrote in the New York Times. And she wrote about her daughter, Orly. And this is something I talked to her about. She ended up having lots of regrets, and you'll hear it very, very loudly in her article. And I talked to her about my role and how I really feel like a huge part of my role is to help prevent regrets, because parents might have regrets about all sorts of different things. And when we think about all these different things they might regret, the difficulty is that almost any regret makes it more likely that parents will have higher levels of anxiety and depression, miss more days of work, they have worse quality of life, and even higher mortality rates. And so we really have to recognize that appropriate grief and bereavement support, including taking the best care of that patient possible while that patient is alive, while that child is alive, we are really a critical component of the family's grief and bereavement journey. And it's really a public health necessity that we do a better job with this work. And so we're creating and have created, and we have a very strong at Stanford Medicine Children's Health have a very strong grief and bereavement program. And that grief and bereavement program is one where we do all these different things. We did this at St. Jude, and we're now doing it here at Stanford, where we think about direct counsel with families, parent-to-parent mentoring. We're doing research. There's staff interventions related to moral distress. There's education, and then we do proactive bereavement care planning with each family. And I want to share with you another video as we're starting to wrap up here. And this video is two precious parents who have taught me so much in my journey in palliative care.
Brand new episode of the Anthony Burton Show. We're doing a little game show, not too big, but a little one, about true or false questions about...
My son Nick was, he was always a very smiley kid until he got to be a teenager, and then he thought, it's too cool to smile. Starting in the probably late fall, late October, early November, Nick started getting headaches. Just like my mother's instinct was telling me, no, something more is wrong. And sure enough, did a bone marrow biopsy, and that's where they confirmed that he had leukemia. At the end of July, Nick woke up with a backache one day, but I knew that was not a good sign. He said, I'm gonna try to sleep, I'm getting a migraine. That migraine was a brain bleed, and he did not wake up from it. He was here 6 more days before he passed away in the ICU.
Back when Nick was dying, we didn't have a palliative care team. Pediatric Palliative Care as a entity was very new. And so Wendy actually partnered with our chief nursing officer at the time. Here she is, a bereaved mom from Ohio, and she is standing in front of the CEO of St. Jude saying, we gotta do better. And I gotta tell you, St. Jude embraced it, and here we are today now with 30 bereaved parent mentors. No program exists like this on the planet.
I met Debbie Higgins way back when the Family Advisory Council started. Her son Carson had been a patient here since he was little guy. And so he's doing well, just coming back for checkups and all at that point. Debbie was a friend of mine who was never afraid to ask me things that nobody else wanted to, about my grief journey, about living without my son. And I shared with her honestly what it was like and the struggles and the different things that I felt and went through.
So what I learned from Wendy originally was that she loved to talk about Nick. And some people didn't want to listen. We cried a lot, we laughed a lot. I think when you lose a child, you appreciate the fun things, the important things a little bit more. And so, it's why sweat the small stuffs? Right before Carson was diagnosed, when he was 3, we were planning a 6-week out west trip to visit all the national parks, and then he was diagnosed with cancer.
And I remember when they came to us after the disease had come back again, after that stupid neuroblastoma had started to grow, Carson was in a lot of pain, and we were using medicines to do our best to treat that. And she began to talk to us about this idea of, I think we need to take a trip.
When he was getting really sick and we knew that they had told us that he was going to be terminal and they couldn't do any more to cure him, and we asked him what he would want to do, and he wanted to do that 6-week trip that we never got to do. It was a trip of a lifetime. And the palliative care team, they set up appointments at different hospitals on the way. So they gave us giant boxes of supplies, puke bags, masks, medication, everything that they could think of.
They would contact us here or there along each point along the trail. They'd send pictures, but they'd also send us, you know, Carson's a little more nauseated today. And so our job was to do the very best to take those symptoms away. Our job was to take Debbie's mind off of things so that she could focus on Carson. So the family, the entire family, the 4 boys, everybody could really focus on Carson.
I feel like if we hadn't had that palliative care team working with us, then we probably wouldn't have been able to do the trip either. Our stop at Las Vegas, about 7 in the morning, we woke up to gurgling sounds. They did CPR for 90 minutes. And I just said, Carson, thank you so much for fighting to come back to us. And I said, but it's okay to go to heaven. I said, go be with Jesus and we'll be okay. And literally, as soon as I said that, his heartbeat stopped.
Some of us gathered up at the airport. So that was hard to see them come off the plane and then the casket come off. So there we were. All of a sudden, 2 moms whose sons were gone.
Fortunately and unfortunately, I had learned already so much from these bereaved parents. It was just incredible. Like, they sent me a book that each holiday, this is what we did to get through things. They found counseling areas for my family and just so many things.
This is really what our QoLA team bereavement program is all about. This circle of giving, this incredible compassion that each past bereaved family hands to the newly bereaved family is such a gift.
Every child that's here leaves their legacy. There's a part of them, even though they're gone, there's a part of them that's in us that they have left because of the life that they lived. If we can take that part and find it, their mark continues on.
I still keep up regularly with Debbie and Wendy from that video, and I shared this last week, and they were so grateful that I was continuing to use that video to teach people. And you know, people like Debbie and Wendy, bereaved parents, have taught us that we have a responsibility and that as an institution, we need to continue to support these families through events like Days of Remembrance like we have here at Stanford, and that we need to continue to engage them. And we just recently had an event where we had 2 amazing bereaved parents, Mina and Amir, come and share about their daughter Yekta. It was the first time that they shared, and they told us that just being able to speak about her created a new memory about her and was so meaningful and so important. Finally, as we close, I want to tell you that access to specialty palliative care is a right. It's not a privilege. And I would encourage anybody who has an opportunity to refer to us to hopefully refer to us early and often. And even though we improve outcomes and there's good data now showing this, and I don't want to call it like the highest quality data, but it's very strong data and study after study after study showing us this. But this is kind of how we're treated pretty often when we come in as the pediatric palliative care team.
Hi. We got a call that this house is on fire. How can we be helpful? Well, the house is on fire, but I'm worried if you go in there it might send the wrong message. Wait, what? I'm with the fire department. Yes, I know. I think you could be really helpful. but I think the family might be worried something is wrong if the fire department shows up at their house. But something is wrong. Their house is on fire. Do you think there's any way you could talk to them, but not use the word fire? What? I just think if the family hears the word fire, they might lose hope. But I am with the fire department and I am here to help this family with their fire. Right, totally. I think you could be really helpful, but I'm just not sure this family is in a place where they're ready to meet the fire department right now. Can we call you the water support team?
Can we call you the water support team? Well, we heard this time and time again as I was starting in the field, and we would be told that families aren't ready. And so we decided to study this. And this is my actually most commonly cited article at this point. And what we found is that it's almost never the parents nor the children who are not ready. Unfortunately, it's usually the clinicians that are projecting that onto the patients and families. And we as the medical community are the most common barrier to early integration of palliative care. And that really matters. You know, the World Health Organization has recognized that palliative care is an ethical responsibility. And I've been really fortunate to be able to advocate for early integration and palliative care integration into universal health systems at the United Nations. And as we think about it, I'd encourage all of us to recognize and to advocate for access to high quality palliative care being understood as a fundamental human right. So hopefully, as we wrap up, you've come to recognize that integrating pediatric palliative care really does improve outcomes, but really that all of us can make a difference in the people that we interact with on a daily basis by leaning in and being willing to suffer with compassionately those people who are right in front of us on a day-to-day basis. And I'm going to share this last story as we end. And this is a really beautiful picture. And it says the lighter penguin is an elderly female whose partner died this year. The darker one is a younger male who lost his partner 2 years ago. Biologists have followed them as they meet every night to comfort each other. They stand for hours together watching the lights. And I just think that that's what this is all about. It really is all about connection. It's not necessarily the exact words we use. It really is a spiritual, existential, a true human connection at a deep level that can make this profound difference. And I know we're kind of out of time or running up against time, but I'd encourage you to join our global palliative care initiative. You can use this QR code to do that. And then I'm going to stop sharing and see kind of what questions might exist in the chat or otherwise. And I just want to once again, Lisa and Laura, thank you so much. The SMCI leadership, thank you for inviting me to be a part of this with you all.
Thank you so much, Dr. Baker. I'm sure everybody would join me with a virtual round of applause. It's just such an emotive, sort of inspirational talk. I really appreciate your talk today. If anybody has any questions, feel free to put them in the chat. But I can start with one, just in the last few minutes. I was really struck by, the story you had with Jessica and also the other family stories. And they kind of struck me thinking about this audience, that they're almost like these mini process improvements, individualized things that, you've got people together very quickly, like the time limited nature of making something like that happen. And I was then trying to think about, well, what are the lessons from those sort of individualized improvements that we could sort of think about applying to the sort of bigger things around reducing readmissions or some of the things that are at a much larger scale. And it's kind of hard to find the individual patient within that creates the empathy and that brings people together. It's a little bit harder, I feel like, when we think about those particular things that we're trying to improve on. I'm just wondering what your reflections are about the lessons about how we can kind of find the empathy and the motivation to make those efforts happen, when I feel like sometimes it's hard to see, the individual patient within those efforts.
Yeah, Laura, thank you for that. I will just tell you that my excitement in coming to speak with you was exactly that, because I think that the moment we lose sight of the mission being the individual patient and family, or for me, the individual patient and family experience, then we just lose. Obviously, we have to think about this in the context of process and improvement and all of these things, but it's for the individual patient that we're doing that. That's the thing. That's the unit. The patient and family is the unit that all the work of everybody corporately on this webinar, that's our work, is to improve things for each individual patient. I will tell you that my inspiration for coming in as as working with the patient experience office really was to help think about, like, my brain works in this holistic way of, even as we're doing improvement science, I actually can't make my brain not think about the individual patient. And so this is something that I think we have to partner in. And I think one of the most important things that we can do is, in the work that you all are doing every day, is link very closely with the people who are doing the direct clinical work, to make sure we're not just trying to move a metric, but to recognize the people who are, and I think we do a good job of sharing stories and this, but the closer you can get engaged in that and hear directly from parents of patients like Jessica, or of Emma's, or others, it will inspire you to keep doing the great work that you all are doing. But I also want to challenge us a little bit, because the patient experience, when we think about things, or quality improvement in general, or performance improvement, when we think about the metrics we're trying to improve, sometimes it can be about improving that metric and we lose sight of the why. And our why is so critical. It's so critical. It can't be for accolades. It has to be for those individual patients. And it's in there. It's there. And I'm here to tell you, as a person who takes care of these patients in our hospital, that the work you're doing is improving the care for these individual patients. And I think all of you are at risk of losing sight of that, because you can get buried kind of in the data and buried in the larger schema of things. So I think it's a really important concept, Laura. And I actually feel like, and Liz is probably kind of giggling a little bit at my response and also at your question, because I feel like my job is to bring the singular patient and family into all of these discussions, like the patient in the hospital struggling with the thing that you all are working on, and just be able to link that story right to it.
Thank you. I totally agree. And I think that's an important thing. And for myself as an external evaluator, often thinking about how can we elevate the patient voice. I know I try to think about that, but those are great points. I think we've got 1 minute left. So I think we'll just wrap up there. There's a couple questions in the chat, which perhaps you can connect with them individually, or if there's anyone that you want to answer, or if people want to stay on.
I'll put my email in the chat real quick, and people, please feel free to email me, and I would be so happy to chat with you more about things. Oops, I responded to an individual there. I am going to put it in for everybody. And we will, I'm very happy to have conversations, to invite you to our rounds or things like this. And again, I just want to thank you, Lisa and Laura. Thank you to the SMCI leadership for inviting me. This has been just awesome being with you all.
Thank you so much, Dr. Baker. And thank you everyone for joining us today. We'll see you again in January. Happy holidays.